on changes in muscle activity. Our next step is to use this method on a population of males with pelvic pain. I would like to thank the University of Queensland and my advisors and contributor. I wish I could be there, but hope to see you all next year in Toronto. I look forward to your questions and comments.
I'm trying to push the button. Okay, there we go. So we will move on to the second presentation of Danielle Van Rijn. She is a physiotherapist and a movement scientist. She owns a private practice and works at the Prosto Clinic, which is a specialized clinic for proctology. She is doing her PhD on chronic anal fissure at Leiden University Medical Center with professor and urologist Rob Pelger. She is presenting pelvic floor physical therapy in the treatment of chronic anal fissure. Please welcome Danielle.
Thank you for your attention, and thank you for presenting my results of our recently performed randomized control trial. As you said, pelvic floor physical therapy in patients with chronic anal fissure, and these results are from the 8 and 20-week follow-up. I'm Danielle, and I have no disclosures besides the Proctor's Clinic who made it possible to visit this congress. The chronic anal fissure is defined as a longitudinal ulcer in the squamous epithelium with one or more signs of chronicity, with presenting symptoms for 6 weeks or recurrent fissures. We included all men and women aged 18 years and older, presenting a chronic anal fissure and pelvic floor dysfunction, dyssynergia, and or increased pelvic floor muscle tone, measured with digital rectal examination and dyssynergia with digital rectal examination and balloon expulsion test. All patients failed conservative treatment with fiber and laxatives and ointment, and they used that for at least 6 weeks with a right instruction how to applicate. The primary outcome of our study was tone at rest during surface electromyographic registration of the pelvic floor before and after pelvic floor physical therapy. Our secondary outcomes contained healing of the fissure, pelvic floor muscle function, the average pain intensity during defecation on a visual analog scale, complaint reduction with a proctology-specific patient-reported outcome, as called the Proctoprom, and quality of life, measured with the Dutch version of the RAND 36. The treatment consisted of 5 sessions of a mean of 45 minutes in a period of 2 months. All patients from both groups, I will tell you later about my concert flow diagram, all patients received baseline information about chronic anal fissure, the pelvic floor, toilet behavior, and lifestyle advice. Besides that, intrarectal myofascial techniques like traction on the puborectalis muscle or myofascial release on identified trigger points were part of the treatment. Surface electromyography was used with the MAPLE and was used during the treatment with an intraanal probe. Pelvic floor muscle and breathing exercises were combined with this SEMG, and patients used thermotherapy like sitting on a heating blanket also as homework. Details of the study are published in earlier. Patients continued the use of the ointment, which is very important, for 2 to 3 times a day. The results of our concert, our flow was like this. We randomized 140 patients with a mean age of 45 years, 72 women and 68 men. Patients were divided into 2 groups. The first group started immediately with pelvic floor physical therapy. The second group started after 8 weeks. All patients visited the pelvic floor physiotherapist, which was me, and a surgeon from the Proctor's clinic at 8 week, 20 week, from baseline, and also after 1 year, although the results of this 1 year follow-up are now under review. The results of our primary outcome. At 8 week follow-up, the PFP3 group significantly improved from pre to post treatment. In the postponed PFP3 group, no significance was found at 8 week follow-up. At 20 week follow-up, significance stayed in the PFP3 group, and the postponed group improved after they received their treatment. But no significance was found, of course, and we hope that, between groups after both groups received their treatment. Although it should be said that the first group improved even better than the postponed group at 20 week follow-up. Dyssynergia measured with digital rectal examination was found in a large group at baseline. So we think that dyssynergia is a very important part of, probably the problem patients experience in chronic anal fissure. At 8 week follow-up, the dyssynergic pattern significantly improved in the PFP3 group. And after 20 weeks, when both groups received their treatment, no significant difference were found between groups. Increased pelvic floor muscle tone was also measured with the EMG and with digital rectal examination, and was also found in a large group of patients and significantly improved in the PFP3 group at 8 week follow-up. And as you can see, no significance were found at 20 weeks. But probably more important, the fissure, how did it go with that? Is there any fissure healing when you treat patients with pelvic floor physical therapy? Well, what we saw, all patients had a chronic anal fissure at baseline. And in the PFPT group, the fissure was visible in only 46% of the patients. So there was also an improvement in fissure healing at 8 week follow-up. Although not all patients improved and not all patients cured at the 20 week follow-up. And probably other, there could be other things involved. Our secondary outcomes contained a Proctor-Prom scores. It's a specialized questionnaire from the Netherlands, and both groups improved from pre to post treatment at 8 week follow-up in complaint reduction, although the PFP2 group found more, was better in complaint reduction than the control group. The same was found in the FAS pain scores. Also, we saw in both groups an improvement in FAS pain scores. So it could be that patients in, we think that because patients in both groups improved in FAS pain and Proctor-Prom scores, they all got information about toilet behavior, lifestyle advice, and information about their complaints. So this could be a reason that also this group, also the postponed group, improved in these outcomes. When we look at the quality of life, we compare these patients to the reference values of the general Dutch population. We saw an impaired quality of life in 8 of 9 domains of the RAND 36, but after treatment, significant lower scores were found in 2 of 9 domains. And from pre to post treatment, significant improvement in the total group of patients was seen in all domains at 20 week follow-up. So the conclusion is that PFPT is an effective modality in patients with CAF and pelvic floor dysfunction. It significantly improves pelvic floor muscle tone, pain, fissure healing, pelvic floor function, complaint reduction, and quality of life. And I would like to thank all the Dutch pelvic floor physical therapists to join me and to support me in this study during the last years. Thank you.
Thank you very much, Danielle. So we will take the question after the last presenters. I'm sure the audience have a lot of them, so you will have to be patient a bit. So the next presenters is Grainne Donnelly. She's a physiotherapist who engages in clinical practice. She will start her PhD soon on the mechanical and symptomatic and perceptual